I understand it's not the catchiest title of our session today, but it's quite descriptive of how specific we're going to be, because it's a 30 to 40 minute session in total, and there'll be about 10 minutes for questions at the end. So I don't expect this to run for longer than 40 minutes in total. It's a series of 2 webinars. The second webinar will be in 2 weeks, and it will be about the management of risk and self-harm to people with mental health difficulties in the primary care setting. So it's a sort of follow-on webinar to this one. Just a little bit of housekeeping just about the session we're about to have today. Our commitment to you is that we'll try to keep to time, and we're going to try to keep the content primary care focused. Just a little bit of legality as well. The content of this presentation is our presenters' interpretation of the present guidance and best practice. It's accurate to the date, to the best of their knowledge. However, it's your responsibility to check the most up-to-date guidance before relying on the information in this webinar alone, as it may change over time and vary by location. Sorry for that extraordinarily long sentence. So our ask of you is that please may you mute your microphone, just so that's easy for everyone to hear our speaker. And if you have any questions as we go along, please will you put them on the group chat, and I'll collate them at the end, and we can put them to Parveen at the end of the session. There will be a survey at the end for feedback, where you can offer us any potential improvements for the way we run our sessions, or suggestions for future topics that you'd find useful as well. Okay, so thank you, Parveen, for joining us, and please feel free to take over.
So there's no role of essentially of predicting in risk assessment. The prediction of the risk is a fallacy in itself. So if there's one take-home message I would give, is that it's futile to try to predict it. It's about developing an understanding of the risk. The elevation of it is yes, and using those structured performers or tools for prompts and understanding to form a therapeutic relationship with our patients, and that is what helps. So like any other diagnostic assessment, it is about starting from the generics, but being able to come to a very individualized risk plan and risk formulation. Because the other fallacy with the tools is they can give scores, but then they fall apart with regards to the formulations. And it is the translation of the assessment into the formulation and management plan that is the critical component. And that can start right at the beginning if we do not overly rely on these tools. So essentially what we're doing is we are making a structured clinical judgment. For a patient presenting to us with risk of suicide or self-harm, in the end as clinicians, we make a clinical judgment and we try to structure it on the basis of our understanding. So whenever you come into a clinical judgment, then our experience tells us that yes, the few critical components, knowledge about it, update about it, but then is the clinical application. And that depends on our individualized relationship with the patient and the alliance that we form. And that remains a tool not only for assessment, but as I'll present later in the seminar, also a very effective intervention. So when we talk about the structured professional judgment or clinical judgment, we are looking at the first stage, which is about understanding the risk. And that is where we get into information collection, the tools, or the interview, and we identify the risk factors, the protective factors. And based on that and based on our understanding, we then come to a formulation, and that is where our judgment applies. And from therein flows the risk management, which includes monitoring, supervision, treatment, and if need be safety, victim safety planning. When we come to risk, again, briefly to the tools, the predictive value of all the tools used for suicide risk is about 5%. That is, we get them right only in about 5% of the cases. 95% we get it wrong with regards to whether we predict them to be high, but more importantly, when we predict them to be low. And that is, again, there's an NKISH research paper on this, including the mental health services. So even when rating by the mental health services, when people die within 3 months or even at whatever the duration, the risk is for most of the patients, even who die, are deemed to be low. And that is the fallacy of relying on any predictive scores or other things. So with our judgment, what we're trying to do is an estimation of the risk. And then we try to come to a balance between certain conditions that we assume are protective factors and certain that we assume to be factors which worsen them. And again, the literature would say that all of them have a bearing on the act of the suicide. So the National Confidential Inquiry on Self-Harm and Homicide, Suicide and Homicide, which is based at University of Manchester, they do annual reports. And from their data, what we know is essentially that annual report is there for everyone to access in the public domain, but we know that the males are more likely to commit the act of suicide. The age groups of 35 to 59, they are more suspect. But in the latest edition, that is a 2019 report. So for the recent trends, what they've shown is the cohort of men aged over 75 and over, there's an increased suicide rate. Women about age of 25 and under, there's increased suicide rate. And we know the suicide rate is increasing in the young population in the universities or colleges. So these are the recent trends. So in the suicide literature, when we try to understand the risk factors, we usually coin terms which are static, dynamic, stable. So static very briefly introduced to the ones which are, again, well established, well associated, but are not likely to change. And these are to do with gender, these are to do with social demographics, social deprivation. So the male gender, the age, but we can see that even the statics over a longitudinal period of time can change. So what would have been not significant age cohort of young women, but that is now significant over the last 3 years or so. And similarly, the elderly aged 85 or 75 and above, their rate increase is again getting worse as the years are going through. The good news is the suicide rates in general population and England have decreased, including the ones of the population under the mental health services. And the increase has been there for the past few years, especially if when you look at the rate of suicides as per the proportion of the population. So if we factor in the increase in population size, then the rates have significantly reduced. So then we come to the dynamic factors. These are, as the word implies, are quite interchangeable, and these could be to do with relationship difficulties. These could be to do with the substance misuse, things that keep on changing in an individual's life, and they might have a bearing. And it is that one factor might change and change the whole risk profile. So for one individual, just the introduction of cocaine or anything into their meal might exacerbate the risk, or coming back into an environment where abuse is there, or moving out of environment where the needs are met. And that is the thing when we say that it needs to be individualized. So what the annual reports or the suicide data tells us is that patients who have recently discharged, who have recently been admitted, and within 3 days of discharge or within 1 week of being with the crisis resolution home treatment teams, that's when the most completed suicides happen. And when we look at these cohort in primary care, so there's an interesting pattern there as well. One is they have made contacts with their GPs in the last 1 year, but that by itself doesn't help. But yes, there's an increased contact by these patients in the 12 months preceding the act. And if there have been, if you look at the 12-month period, it starts getting significant after about 15 contacts, and definitely highly significant if there are more than 24 contacts within a year. But if we know our patients and we know that they have got mental health, if we start putting the pieces together, and that's what our structural clinical judgment is. Patient with mental health problems, which we know increase the risk. Patients with substance misuse problems, dual diagnosis, or other vulnerable factors which we've talked about, unemployed, male sex. And then if their contacts start increasing, so then we are on the alert. But equally, the patients who do not come into contact at all. So these were the two cohorts, too frequent a contact or no contact at all. So this is the pattern, especially for patients who are known to the services and who are known with these mental health problems or these presentations. So if we see these change in their attendance to the practice, then that initiates a sort of a red flag or further investigation. So then what we say is, we know the static factors. We know, apart from that, is that the psychotropic medications, safe prescribing remains there. And currently the focus is on safe prescribing for opioids as well as benzodiazepines. So the most common method of death currently is hanging across general population. And then is the overdose. Amongst the overdose, opioids have increased and the prescribed overdoses are the most common now, rather than the illicit ones. And therefore, it is the looking at a rational and evidence-based analgesic control for chronic conditions. And similarly, for the patients in primary care, majority of them did not have let's say 1/3 of them do not have a mental health diagnosis, the ones who die in primary care. And that doesn't mean that they don't have a mental illness, but perhaps they have not accessed it, and they have not, because we know that the male population does not access services quickly. And more than half of them would not have been prescribed a psychotropic medication before they died, even if they had a recorded diagnosis. So these are the relevant findings in the primary care from the annual reports of the National Confidential Inquiry into Homicide and Suicide. So we know these mixes, and there are more details there about greater than 50% of the population of substance and misuse with mental health problems. They are represented in the suicide population. About 56% would have substance misuse problems, and a very minority of them would be with the services. Similarly, with the young women, we know they're about, we talked about the age of 25 or roundabouts. They come with a triad of self-harm, personality disorder, and substance misuse. And most of them, unfortunately, because of the personality disorder, do not get the recognition about the self-harm risk or even the substance misuse risk. And mostly they are labeled as low risk because of these are the misconceptions there, that females do not die of suicide that frequently, and personality disorders, it is a cry for help or attention seeking rather than a true attempt. But this triad, and significant of them also have eating disorder difficulties. So we see these women service use hours, but then we don't perhaps give the valence to what it should be. So coming back to what we say is the assessment of the risk. So apart from making the structured clinical judgment based on these factors, static, dynamic, stable, or what might predict in the future given the individualized circumstances of the patients. And they, I say, are quite well researched. One of the things which is a pillar of reducing the suicide rates is effective management of depression in the primary care. So yes, we have walked away from predicting the immediate risk, but we still need to translate that into how do we offer our services. Now, when we're doing a clinical judgment, we're relying on a clinical interview, and one of the major factors that we rely on is the stated intent of the patient. And there's again robust evidence to say that it is not always most reliable reporting by the patient who is determined to carry out the act. So inherently, we are aware that it cannot be there's no 100% foolproof risk assessment of the nature of the suicide act. And that is not what the coroners or the others are looking for. It is about the comprehensiveness of the assessment. And we have looked at all the factors, the social, the psychological, and I've enumerated a few of them, and they're well established in the literature about what I've just alluded to. So we have made those, and then we have looked at the risk and developed an understanding, and that reflects the reporting by the patient on the day. So when we know that, yes, the intent itself might be reported differently and for valid reasons. So the literature does classify into the articulated intent and the reflective intent of the patient and the unarticulated content as well. So it's about exploring the reflective. So it's about encouraging the patient to talk about what is going on in their head. It is about talking about when did it start. So getting the patient's narrative. And that might come out and reduce the barrier of getting into details of the intent. Because, again, this is now common knowledge that talking about suicide does not increase the risk of the suicide. But it's about not just taking what is being said at the face value, but then getting into the what makes the patient think either way less, or if they report that was in the past, what has changed. So allowing them to reflect on their suicidal thoughts and suicidal plans or the lack of it, getting that narrative, and then the story starts building up. And we do say, looking at the chronological assessment, which is if there were attempts, then going into a bit of detail, what they did, how they planned, when they made the definitive attempt, what prevented them in the past. So these narratives help. And then getting this narrative into a formulation, tying up right from their childhood experiences to their vulnerability, to their strengths. And the strengths have to be, again, understood in the context of the patient's current situation. Because frequently identify current, the protective factors cited as children, or family members, but they might have not have seen their family members, or they might have sent the final communication to the family members. So it's about getting into the context of, is it still relevant, and what is the relation and what is their engagement with those protective factors. Because these are the things that we rely on, the vulnerability factors, the stated preparedness for the act, the factors which might influence it, and the factors which might protect against it. So then we know, again, it's not for me to say, everyone knows a psychiatric diagnosis, active psychopathology, be it psychotic, be it depression, be it anxiety. Any active features of mental health, they increase. Fine. Chronic pain syndromes, they increase the risk of suicide. So then the effort has been to look at how to still make the structured judgment about if someone is likely to act on these in the immediacy, and how do we get there. Again, there's no robust literature which says that if this is evident, then we are sure of this happening. So therefore, the emphasis is still on the biopsychosocial assessment, getting into all the relevant variables. But yes, over the years, there has been a drive in the research itself to look at identifying within a given mental state what could predict or at least correlate strongly with future suicide attempts. And there's a reasonable research evidence to say that few things, and that is again borne out by the last year's report, anxiety, worsening of anxiety with agitation or hyperarousal symptoms, hypervigilance, agitation, irritability, insomnia. If your depressed patients are presenting with these or otherwise, then yes, that does lend them to perhaps acting on their suicidal ideation more as compared to the ones who do not have these features. And then there's another strong element or variable, which is recognized as entrapment or mentioned as a feeling of entrapment or loss of control, getting overwhelmed. And this is when the patients say that they have a strong urge, or what they want is to escape and get out of from whatever they are, whatever situation it is. They just want to not to be there, but they cannot help it. So that feeling of loss of control, a feeling of being entrapped, overwhelmed, and a strong urge to not to be there and feeling helpless. So these are again identified as having strong association with the future predictability of or association with the completed act. And then there's excessive ruminations and rigidity in thinking, where they cannot think of alternatives, where they're thinking only of exit as the only plausible solution. Apart from, we know that if they have many of the patients describe is emotional pain, and that is a feeling of anguish, hurt. So this is the exploration that we try to do with the patients about what is in their mental state and if they reflect on that. And if that then ties up and correlates with the intent, then that gives the increased confidence. And therefore it is individualized. We cannot have a generic template and we cannot have a generic tool about getting this right for our patients. And we fully appreciate the difficulty is that within a 10-minute appointment slot, how do we get there? But the challenge is perhaps looking at these, and if they require more attention, then perhaps looking at where we can get them. And that would have to transcend both primary care and secondary care. So depending on, we know that any act of self-harm by itself is the most robust predictor of future suicide and future self-harm. So it starts at the first instance of self-harm, and we need to get there. So then we're talking about the therapeutic relationship between the therapist and the patient. And here you, my colleagues, are in a unique position because you have a longitudinal relation with your patients, which is on most occasions positive. And that helps in getting through, and you have these life events perhaps from the patients narrated previously. So the robustness in your assessments is going to be far more than when they come to us, because it takes time for them to entrust us to come up with those things. Yes, the art of the craft is that, yes, we have to get there. But therefore, we uniquely complement each other with regards to what we can offer in terms of information surrounding this. And therefore, the communication has to be strong. So there has been research which has been done about what do the patients want when they talk to the clinicians. And they want, again, a personalized approach. They do not want a checklist. They do want to have staff who are well-trained and have an understanding of managing distress and who value the answers given. So acknowledging the answers. So those fundamental principles of a good psychiatric interview, empathic listening, reflective listening, those are the cornerstones which the patients also appreciate. And they do want to focus on suicidal thoughts and staff to confidentially tackle the difficult questions. And there are, again, an array of approaches there. And then involving carers, families, they do want their families to be involved. But of course, we take their consent. But even if they do not, if we pursue and we do it repeatedly, we do tell them that we have to share the risk. and we have to collate the risk information, and that forms a good platform of further collaboration. And they want information to be provided about the local support, not the national helplines. So they want what are the local options for helplines, 24-hour services, and where they can access. Similarly, what the carers want is to have an understanding and knowledge of the care plan. Frequently, patient does not tell them about the actual risk or the actual mental state, but they are burdened with the care where they are involved in the care, and they themselves are even less informed than the patient, and they're more frightened because of the gap in what they know and what they fear. And the patient might not be in a state to discuss with them or help them out there. So therefore, getting information, advice on what to accept, how to manage the situations at home before and during a crisis. So that's again collaborative working. And that is what their expectation is, rather than being told to what to do and what not to do, but have a discussion about what will help, what they can do to help, and when they need to escalate. And yes, they would value training to develop the skills and knowledge to support the patient, including in a crisis. And that Public Health England also recognizes, the system recognizes, and there are treatment portals or modules which look at getting the awareness about suicide and how to help to anyone out there. Not professionals, but the general population, and that also helps in improving access to services by the high-risk group of males that we've talked about, the middle-aged male, be it in the transport industry, be it in other industries.
You've brought up some really interesting points. Thank you. I feel that this webinar is going to be too short to cover everything, but based on what you've said already, there's been a couple of questions, if you don't mind us putting them to you.
Yeah, sure.
Thank you. Sujit Bazan has asked, is there any information about online risk assessment versus face-to-face versus telephone? Obviously, at the moment, we're doing much more online consultations and telephone consultations. Is there any evidence about how useful they are or what the risk is in association with those?
Yes, there is a study, but sorry, I haven't been able to cite it. And we did try to do a similar sort of exercise on getting the professionals' viewpoint, but we're hampered by not getting the patient's viewpoint on that, just because of the, again, difficulty in accessing patients. But yes, it has to begin a complete package. So essentially, when you're going in for the first time, it's good to have a comprehensive assessment, which is having the patient face-to-face, because majority of our interview relies on the non-verbal communication. So verbal communication is there, and we have just, if you look at what we have talked about, the patient's readiness to disclose their actual mental state. So initially, we would want one assessment to be face-to-face. Then there are unique characteristics of our patient population, especially present in distress, and that is domestic abuse. And these are not served well by the online consultations. So therefore, sometimes the sanctuary of seeing a clinician is perhaps what is providing them the encouragement to go further in their disclosure about the domestic abuse and everything. And that might not be feasible for them within the teleconsultations in this. So it is about, but yes, to look at this very robust evidence, there's one study, but forgive me, I don't have the results in front of me. And there are planned studies to look at but the red herrings are about relying too heavily on them. Again, this a quick closure without looking at the actual risk. So if need be, if there are concerns, and if we are looking at either cryptic answers, and we do get very quick answers on occasion, closure of the questions, when we look at the risk and things are being said to be fine. And when we're looking at multiple comorbidities, which also include substance misuse and everything, where we know denial and underreporting is the rule, then it's worthwhile to have one, more collaborative information, other, if visible, a face-to-face comprehensive, and then the follow-ups can then be determined by what you have gathered in the initial.
That's really interesting. Thank you. I'm so sorry that it's not worked out with your PowerPoint presentation today as well. We have a request from one of our GPs asking if it would be possible for us to see PowerPoint slides at all.
Yes,
if they could be emailed.
I'm happy.
Thank you.
Yes, yeah. So
I can send them round to the emails that I get through the feedback. So yeah, and we'll try and sort it out that it works next time. I'm not quite sure what's happened there, and if worst comes to the worst, next time I can just I can do the PowerPoint from my computer. That's not a problem.
Yes, yes, that's what I should have done. But you know, that's what previously it was.
These things happen. It's new to us. It's new to us all. It's a new thing we're setting up. So please bear with us on that one. So there's another question as well from Rob Lamb. From his reading of the guidance on remote consulting, it was suggested that video was preferable to telephone. It may be worth us considering our preference of consulting method. So from that, I understand that you're pointing out that the patient's preference and our preference might alter as well, which is leading on from the last question.
Yes. Thank you. And absolutely, that's absolutely true. And that is the preferred choice for our services as well, to have a video interview. And I think so, Attend Anywhere is available. So that is rolled out for the secondary services, including the Q Trust and both the Northwest boroughs as well as our Royal WWL. They both have invested into this, and it's an NHS tool, Attend Anywhere. And the beauty of it is it just requires a hyperlink to be given to the patient. They don't need to download any app. They don't need anything there. It lends itself to a waiting area. Our primary care colleagues using it. The Attend Anywhere software. So that should be the preferred one. So that should be the preferred one. And again, the caveat is yes, video consultations definitely for the reasons my colleague just mentioned. But again, keep the caveat that they might still not control everything in the environment.
Indeed, like you mentioned about the domestic violence issue, which is an interesting point as well.
Yeah, so the clinical curiosity remains the hallmark. Yeah. Empathy and clinical curiosity, that remain the strongest tools we have. Empathy allows us. Sorry.
Were there any more questions from the audience at all? I did have one question, actually. I found it really interesting. In the time that I've been training, the evidence has switched from, we used to teach initially that self-harm was an independent factor and it wasn't directly related towards suicide risk, but that seems to have, the advice on that seems to have changed in recent years. You mentioned earlier that any self-harm is a warning sign of risk.
Yes, the literature would suggest that, it remains one of the most strongest predictors. Self-harm, not only of repeat self-harm, but also of suicide. So it predicts both.
Yeah.
So, and they predict, more than half of the patients in certain studies would correlate with the past history of self-harm. There's one thing which I would say as just take home message because of the short after time, but I can take it next time. The assessment that we have talked about, that can reduce the risk, and that's again borne by evidence, by about 40% in the acute, in the here and now. So if you take it, that rest of the interventions will take time, psychological interventions, pharmacological intervention, everything will take time. But a good biopsychosocial assessment reduces the risk of repeat self-harm by about 40%. and that's borne by evidence. The other things are safety planning on the day and follow-up. Even any intervention, household brief helps. So it's about if you get that relationship right, and if you offer anything that helps.
That's really useful, and actually I find it quite reassuring as well, actually.
Yes, but my plea is that if they need your time, they need your time, and if you're not, then we need to look at how the primary care can offer that. We are going forward with mental health workers or another in the PCA networks, more mental health involvement, or if there's another professionals, or so to do justice to what your workload demands, but to do justice to the patient. So that offer is what I would say we need to look, and so that they can be helped at the first contact itself.
Oh, well, it's been really interesting. Thank you so much for giving us your time. I look forward to the next webinar as well, where hopefully it'll run smoother at the beginning and we'll be able to run to time a little bit better.